Thank you so much for the excellent talks. We're running about 10 minutes behind, but I don't want to not have a question and answer session, so we'll make it slightly abbreviated. I think there are a couple points, and there have been some good questions coming from the audience. I do want to, just my own first question to Dr. Valent, a clarification on one statement about free light chain testing on the urine. When you said that it was always wrong, you were referring to the application of the free light chain assay, not measurement of Benz-Jones protein.
Correct.
Right. Just to be clear for audience members,
yes.
You're saying, I mean, the free light chain testing is most effectively used on serum. And not the utility on urine is less clear. Correct.
I would argue, urine free light chains are completely useless in plasma cell disorders.
Okay. Now.
Here, question.
Questions that came up. There's a few. The first is with regard, and I knew this was going to come up, was with regards to the role of venetoclax. I think this is something that a lot of people are, really interested in, given its efficacy in myeloma with 11-14 translocation and the higher frequency of the same translocation in AL amyloidosis. So I'd like to put to the clinicians here in the group, are you using it as part of first-line therapy outside of a clinical trial in any patient subsets? And whether or not you are, when you use it, whether it's second line, whether it's later, how are you using it? Are you using it by itself, with steroid, with other chemo? What dose? Do you do a ramp up? What do you do?
What are you asking?
I'm asking.
All right, I'll go first.
I'm asking.
I'll take the sword. So I don't use it in the front line. So our standard is generally DARA VCD, but for patients with a T1114 who either don't respond or have a less than desirable response, I will generally use it second line in combination with bortezomib and dexamethasone. We do 400 for a week and then 800 daily, and I generally do it for 6 months and stop.
Angela, please.
No, go. You're next.
We go like this?
Yeah, that's up.
We never use it first-line therapy. As first-line therapy, we use it either as second or third-line therapy in patients who have not received daratumumab. We usually use it as a single agent, perhaps with a little dose of steroids. In very few cases, a little small dose of bortezomib, but generally as a single agent.
Yeah, I do pretty similar in terms of single agent, maybe with a little steroid. It's extraordinarily effective, not for frontline just because you can't get it. I mean, I think it's a wonderful clinical trial question, et cetera. And you can get it compassionate use often in the US, or there are trials that are coming to use it as second line or third line, whatever. But really great drug, and unclear to me how much you need combination therapy with it. I would do it additive.
The dose that you use?
Yeah, I get to 800, so 400, and then within a little bit 800.
Okay. A next question. I mean, other than the obvious mantra that we all say, that earlier diagnosis is going to be the key to solving early mortality. But I think what we saw in both the transplant and non-transplant talks is that we still have an issue with early mortality. And so other than finding the patients earlier, what strategies, how are we approaching that, and what's in development to try and tackle that particular issue? Why don't either Dr. Dispenza or Dr. Kostidis?
As you pointed out, early mortality is a big issue. First of all, we have to be very careful with the use of the drugs that we have in our hands. For example, we have to be very careful with the steroids, with the dose of the steroids, with the schedule of the steroids, with the use of diuretics, We have to emphasize the need that the patient should have a very careful evaluation by cardiologists, nephrologists. This will allow us to reduce somewhat the early mortality. I think for patients with very advanced cardiac disease, the current approaches that we have for hematologic response, even if they achieve a hematologic response, are not enough to save their lives. And we definitely need something more. I don't know if this is going to be one of the new monoclonal antibodies against amyloid, or the approach that Angela also showed, the need for early organ transplantation to save the lives of these patients. But otherwise, with the current approaches, I don't see much space for improvement.
Yeah, I'd echo that. I think, daily weights, really good cardiac management, making sure that the cardiologist that's helping you actually knows something about amyloid, that they don't put them on standard heart failure therapy with lots of beta blockers and after load reduction, because you're just going to really you're going to do a bad deed if that happens, and we'll hear more about that. But yeah, really meticulous electrolyte and fluid management is going to be essential. And then, looking whether heart transplant, easier said than done. Hearts are hard to come by. But I think a patient in CR with very advanced cardiac disease certainly should be considered.
Dr. Dispenzieri, can you comment on ongoing clinical trials about monoclonal antibodies in for this patient population?
Yeah, so there's the CALM studies. There are two. One is for newly diagnosed 3A disease and 3B disease. They're separate, but I think that these are going to be, that's going to be quite important. Prothena also is going to do 3B. That, to the best of my knowledge, I don't think it's opened anywhere yet. It's close, but it isn't open yet at our institution. Is it open?
We're open.
It is, okay, the Prothena, okay, sorry. We're slow, so it is definitely open. But the CALM's open, but the Prothena is open then too. We're working on ours. So those are great options, and I strongly encourage people to refer patients in, because it is such a group that needs help. And if these antibodies work, that would be tremendous.
Okay, I'm going to I think I'm going to do two more questions before we move on to the next group of speakers. The first one, there are several questions coming through from the audience about PYP scans, and I know we're going to talk about those in the context of ATTR specifically in an upcoming talk, but I guess a question, and maybe we'll start with Dr. Judge on this, is how often does a PYP scan complicate or help, the diagnostic workup in a patient who 10 years ago, 15 years ago, we would have just said had AL amyloidosis?
Yeah, so the PYP scans are great, really. They're a nice new addition to our regimen, but they're not perfect. And so in my practice and in lots of cardiologists who focus on amyloid, what we're seeing more often now is people who are referred with false positive PYP scans. The assay was developed in a cohort of patients that were very suspicious for amyloid, ended up having a sensitivity of nearly 100%. The specificity was close to 100%. And the only place where the PYP scan failed for specificity was AL amyloid. So in other words, you can have zero uptake on a PYP scan with AL amyloid. You can have high-level uptake, and we can't discern those. So while the PYP scan is very helpful, once you've excluded AL amyloid, it doesn't by itself exclude amyloid. It doesn't exclude AL amyloid.
Perfect. And then last question. I'll just pick one here from the audience because it does, I think, speak to something. And I did neglect to mention that Dr. Milani is logged in and online and is also here. And I'm wondering if Dr. Milani can hear me and is able to participate in this part of the discussion. Do we know? not certain. Ah,
There he
okay.
is, there he is.
There is Dr. Milani, all the way from Italy. Thank you. I'm so glad you're here.
Okay.
I know that you're going to, in your talk, start to get at the question of when to switch therapy. And in your talk, as we'll see, it's mostly about when to recognize, when to resume therapy when you start to see light chain markers changing, and resuming therapy when you suspect hematologic progression. One of the questions that we got, and this was actually addressed specifically to Dr. Dispenzieri and Kastridis, but all of our clinicians can answer this. It has to do with the question is specifically a patient has achieved a partial renal response with residual a patient who presented with heavy nephrotic range proteinuria, achieved was treated on Andromeda, achieved a hematologic complete response, but then at cycle 11 of maintenance therapy, still has residual proteinuria. And I guess the question that's being asked here is, are there circumstances in which failure to achieve an organ response itself would be an indication to switch therapy, or does hematologic response completely drive that? And I welcome I welcome the opinion of any and all clinicians on the stage. We have a nephrologist on the stage, and please, all of the hematologists or the cardiologist, please, I'm interested in your opinion on this.
I mean, median time to renal response is about 9 months, and best response can take years. So again, I think, you're starting to, if you're having some renal response, I think you need to be patient if you're in CR. There are patients, though, who still have, they're in CR, but their bone marrows are positive, and, you've been waiting several years, and, not much is happening. Sometimes you say, okay, we know there's a clone here. We've been really patient. They haven't even gotten a 30% reduction or whatever. Maybe that, underlying clone that's in there, even though I can't see free light chains anymore and I can't see immunofix positivity, let's give it a shot and try some therapy. But 9 months is short to, feel like you should have perfection.
I totally agree. I don't think that we can say that the treatment is failing in a patient with complete hematologic response who has not complete resolution of proteinuria. Beyond proteinuria, I would also look, for example, at the levels of albumin in the serum. So if I would see serum albumin going up, even if albuminuria stays at the same level, I would feel more comfortable, and I would wait, and I would evaluate at some point for the presence of minimal residual disease in case there is a small amount of free light chains that cannot be detected and is not allowing the improvement of organ function.
If the question had been slightly different and it had been if proteinuria were still increasing, or a harder question, in my opinion, if GFR is decreasing in the setting of persisting proteinuria, do you ever modify therapy in a patient who's not in CR at that point? Even if they have a response that you were satisfied with before you had that renal deterioration?
Yeah, I do. I mean, you get desperate and you're like, you have a frank conversation and you say, I don't know if this is going to help, but let's see, is my view.
And also depends on what therapies you have
left.
Because if you have failing, eGFR going down and what you have left is lenalidomide and a lot of proteinuria, maybe the solution is not very good. I don't know if,
Yeah, I agree. It's always a difficult discussion. We have these discussions at BU with Dr. Sanchavala all the time. Shall we wait? But then my point is that, okay, but then we will lose the kidney. But the other side, we are doing toxic treatment, if available, right? But these are toxic treatments. So are we going to help or are we going to harm? So these are hard decisions, and it has to be individualized. And sometimes we win, sometimes we lose, unfortunately.
I mean, sometimes there was a crisis, they got septic or something, and so they had a hit in their eGFR, and, so you have a reason, right? You're not blaming it on the amyloid clone per se. They had some incident, they got dehydrated, then in that instance, you have a cause, so I wouldn't change therapy. But if nothing like that's occurred, and the only thing I have to possibly blame is the clone, then I would think of it.
Dr. Milani, I'm going to give you last word on this before we move on to the transthyretin talk. In your own practice, what would you do in that circumstance?
Thank you. I agree what was said by Dr. Dispensieri, because we had the same approach, and probably we are checking MRD in those patients. And look, maybe this for the patient in CR, so the first part of the question. For the second one, I agree with Dr. Castritis that we need to check carefully what we have in our treatment approaches to decide.
Okay, thank you. Oh, we have a question, a live question.
If somebody, I don't think a microphone is on. I'm Phil Scheinberg from São Paulo, Brazil. If somebody has such a good hematologic response and the kidney has still not reached that level of satisfaction that we would like to see, would a renal transplant be of any benefit?
So in case everybody in the audience couldn't hear it, the question was, in a patient who's had a good hematologic response but still has significant proteinuria or impaired renal function that hasn't recovered, is renal transplant a viable option for those patients? Maybe we can start with Dr. Dispensieri and then Dr. Havasian.
So, people can live quite well with an eGFR of 20 for some period. I mean, so you kind of ride that out. But, if they're getting an eGFR of 10 or, signs that they need to go on dialysis or whatever, then certainly I think a renal transplant is a great option.
Yes, most of the people who achieve CR or VGPR, they are reasonable candidates for kidney transplant, so we can try. Not everyone does well, but most of them. So yes.
Okay. We have one last live question, and then we're going to move on to the next talk.
Yeah, this is my patient to send a question to you. Actually, he achieved MRD negative remission on the bone marrow from a plasma cell perspective. His albumin is improved in the first few cycles and then plateauing from 18 to 32. And his proteinuria was heavy, like at 8 to 10 gram per day to 2 gram now. Question is, how frequent do we see late responders from a renal point of view? And do transplant is offered at this time point or not? He's at cycle 11, receiving DARA maintenance.
You're saying cycle 11?
Yeah, cycle 11.
Again, I think you can still see response. So I think as long as things are going well, time to maximum response is, again, 2.5 years or so. I mean, it takes a long time. Are you saying there was no, the albumin's coming up, but the proteinuria is not improving?
Yeah, it's not improving.
The other thing also, if you're doing 24-hour urine, sometimes patients trick you. They will sometimes do an incomplete collection, so you end up with maybe your first urine is like a 12-hour urine. I always look at the volumes because it makes a difference, right? Because they have concentration and then they multiply it. And so you want to make sure, with the albumin going up and if the eGFR is stable, I would say you're really going in the right direction. But I'll defer to.
And with the 24-hour urine, one more point that you can check the total creatinine excretion in the urine. And that depends on your age, muscle mass, and gender. So we have a goal for a certain patient. So we always monitor that and we make sure that it's a complete collection and it's comparable to the previous collection. So that could help with the determining if it's correct, the number or not. And I agree that organ response lags behind, and sometimes it's a long time. So you have to decide how patient you want to be. And hopefully the patient can keep the kidneys while you are waiting for organ response.
Okay, thank you.